Rachel. Rachel is a specialist nurse practitioner in the FLS service in Oxford, and she's going to talk about bringing AI into the FLS. Thank you, Rachel.
No problem. Thank you very much, and thanks for the two great talks that have come before mine. So the purpose of my talk today is really just to hopefully give an idea of how we have brought AI into an FLS setting. So how we've done that in Oxford, and I will go through that now. This is just my disclosure. I have done some presentations for UCB. So in terms of our service, so I just thought I'd just give a quick overview of what the service in Oxford looks like. So we're an FLS that covers 2 hospital sites. We're based on a third. We are a large FLS, so we're seeing a large number of patients, and we are also lucky to have a large staff base to do that with. So why we went down this route. So, we recognized quite a while ago that actually technology as a whole was really important to moving FLS forward, and systematic identification of patients was key really to be able to make sure that we were identifying those patients that we needed to. So we did work to use some forms of technology to increase identification of what we sort of called the missing tribe. So those patients we classically missed at FLS, like rib fractures, pubic rami fractures. But what we struggled with was to really bring that to vertebral fracture patients. They're classically patients that are not presenting to acute hospital settings, and so the sort of methods that we used to find those pubic rami and rib fractures really didn't work for us with vertebral fractures, as was highlighted in our KPIs. So back in 2016, we identified that we really weren't seeing spine fractures at all, and so that was one of the key things that we used our QI cycles to focus on. And so what that looked like was a bit of a journey. So this looks at our vertebral fracture identification from back in 2016 up until present time now. And so I've just sort of picked up some points and the different things that we used and how we came to end up using AI to do that more consistently. So the first thing that we tried was radiographer-led audit in 2017. So we've worked with our colleagues in radiology within the DEXA department, and we used the reporting, so keywords within reports, to try and pick out patients who had vertebral fractures. That was across a variety of modalities, so X-rays, CTs, MRIs. It definitely had impact. You can see that our numbers spiked, but it wasn't sustainable. It burnt out quickly, and as soon as that extra time of that radiographer was gone, it was just not something that we could keep up. So we then moved on to the first implementation of AI in Oxford, and that was in the form of Zebra, now Nanox, and this gave us a large spike in cases. But again, it really wasn't sustainable just due to the huge workload involved in finding those patients. So even with those early forms of AI, the workload was huge, and the output was just not really sustainable. This is what it looks like. So it was an amazing sort of thing to be doing, but it was still quite basic. So what we got was lots and lots of spreadsheets that we had to work through with very basic patient information, and we were using all sorts of different sort of hospital technology systems still, so accessing across lots of different platforms to try and ultimately find vertebral fractures in these patients. So how we did that was we initially spent some time working with an invested consultant radiologist. So that was a real learning curve. So a couple of us specialist nurses worked with him to really effectively try and learn how to read those CT scans. So the AI was giving us the lists of patient MRN, so patient numbers, who had positive vertebral fracture identification. But what we needed to do was then go in and agree or disagree with that AI to actually then pull the appropriate patients into the FLS. So we spent lots of time looking at normal scans so that we were able to confidently identify what a normal CT looks like. And then we became familiar with fracture and non-fracture deformities, so things like degenerative change, Cupid's bow deformities, Schmall's nodes. And there was no real sort of formal training for this. We had weekly meetings of around 30 minutes to just review lots lots and lots of those Excel spreadsheets that we had with lots and lots of patients who did have vertebral fractures, and importantly, those who did not. So the AI was churning out lots and lots of patients, some of them with fractures, but lots of them actually without. And so it was really important that we got to grips with that. And around 2 months of this, we agreed that actually we would just meet less frequently and go over the cases that we were unsure about. And actually, with experience, this quickly changed to just irregular emails as and when we needed. So that had a really good effect on how we were able to identify vertebral fractures within the Oxford FLS, but we still needed to do more because it was still a very work-heavy model. So what we then moved to is an upgraded and improved version of AI, which helped again to increase our numbers, but we had then, issues as we do within the FLS setting that meant that we still never managed to push it further. But what we got then was a great improvement. So what it looked like now was a spreadsheet of patient information, but also importantly, some images that we could use. So that meant that we could then really start to integrate this properly into our pathway. So we came up with a pre-Ramo. So importantly, this was going back before we had use of romosozumab within FLS. It's changed slightly now, but it made us sort of sit down and map out, right, well, we're finding all of these patients. So actually, how are we going to actually manage to bring that within the FLS? Because the numbers were huge, as was previously mentioned in Kasim's talk, the sort of scope to actually improve the numbers of staff and things like that was not there. So we had to work with what we had to really try and make sure that we were making the most of this technology that we had access to. So we developed a pathway to help try and streamline and prioritize the patients that we were going to see. Importantly, we built in a 3-month lag. So it wasn't hard because the numbers that were being churned out by the AI were huge, but it was really important to make sure that we were not delivering a diagnosis of a vertebral fracture before these patients had actually had the primary diagnosis given to them, because obviously the CT scan that they were having done was in most cases not done looking for a vertebral fracture. This is an incidental finding. We are using CT scans that were done for other reasons to try and pick out vertebral fractures that we were missing. So developing the pathway was a really helpful way to try and make sure that we were integrating all of this into FLS, but there was still work to be done. So where we are sitting at now is a more up-to-date version. So we now have Nanox as they are now, and their platform for viewing these AI outputs, which meant that we could actually be a lot more effective with how we were using it in FLS. So it cut down a lot of the sort of cross-platform work and the time that we were having to put into finding these vertebral fractures, because what it meant was we ended up with something much more like this. So a really workable platform that showed us all of the patients that were felt to have positive vertebral fractures, so we can filter really easily between those that the technology has identified as positive. And then of those positive patients, we have 3 slices now from the CT that we can use. So it means that we could, given the huge numbers of scans that we're talking about, it meant that we could agree that actually this was the platform that we wanted to make our decision within. So we needed to be able to use these 3 images to agree or disagree with the AI output. And that meant that it cut down a huge amount of time, opening lots of different radiology systems, sort of really looking at scans that we probably shouldn't have been doing, and agreeing to look at sort of a grade 2 and above vertebral fracture again made us sort of focus down on those patients that were really the priority for us. And the impact of real. So it meant, as I said, a huge time saving aspect for the FLS when we were identifying these fractures, a quick agree and disagree process that we could then sort of record really easily within that platform. And then actually at the end of that, we can choose a time frame to export an Excel that just contains those positive vertebral fracture patients. And then that can be worked on by the wider FLS in the way that we would do for any other list. So be it a trauma outpatient list or an inpatient list. So, a way that we're used to working within FLS, a list of patients that we know have a positive vertebral fracture who then need triaging in the way that any other FLS patient would do. So that's the point at which we have sort of reached with that now. Despite that, it is really important to note that there is a huge human level here, and the AI is a really, really good way of being able to consistently identify these vertebral fractures. But where the work comes in is then deciding, of these vertebral fractures that we've identified, which of them are we actually going to tunnel into the FLS? So straight away, there are patients that we're going to feed out of the system because either they're sitting on our server and they actually don't live within our geographical area at all, but they've been put into an MDT discussion, for example. And so we're not going to be spending time seeing those patients because they're not within our locality. Unfortunately, there'll be a large number of patients that may have died between the scan being done and it actually being reviewed by us in FLS. Going back to that 3-month lag, it's another really important thing to sort of factor in when you're making these decisions. And then what we need to do after that is then use radiology systems further to actually try and give some sort of date to the scan, to the fracture, sorry. So obviously a lot of these patients have had multiple CT scans, and what that does mean is that often we are able to therefore pin down when this vertebral fracture may have happened. And that's really important in FLS because particularly all of the work that has been done to identify things like imminent fracture risk and also the access to treatments now we have with anabolics such as romosozumab, we want to be able to really try and find patients who have sustained this fracture within the last 2 years as a priority. At the moment, we recognise that there are far more of these vertebral fracture patients than we have capacity to deal with. And so therefore, we're having to make decisions about prioritisation. And one of those decisions is often actually the recency of the fracture. And so looking back through radiology systems, and the other CT scans or potentially MRI imaging those patients may have had helps us to do that. And that's not something at the moment that we're using the AI for. The AI is presenting these patients to us, and we are then doing that groundwork ourselves. What that means is we can then, as I said, give some priority to these patients, and that Excel output at the end should then be a real focused down list of patients that we need to feed through our FLS. There's lots more work to do. We recognize this. The more patients that we see using this, actually, I think what will happen is that we will start to see a slowdown in the huge backlog that we have because there are lots of patients that are having serial scans. So oncology reviews, lung nodule monitoring, these patients are having CTs regularly. And the more patients we get through our system, the more we'll be able to filter out because actually they're duplicate scans and they're patients that hopefully we've already identified within FLS and are already on appropriate treatment. The other important thing is confidence within the team. So, this is a very different patient group. They don't know necessarily that they've had these fractures. So being sure that it is appropriate to invite someone into an FLS clinic to tell them that they've had this vertebral fracture is really important and something that takes time and is something that needs sort of confidence to build within the FLS nursing team to be sure that actually despite potentially some, significant other medical conditions that this patient's being treated for, it is important that we're targeting them and identifying this vertebral fracture. But, delivering that news to them is very different than speaking to a patient who has fallen over and broken their wrist and is aware that they've had that fragility fracture. So all of that takes confidence, and that is a process that is something that is, really important when you're thinking about bringing this into an FLS setting. The other thing is really making sure that this is standard FLS care and not activity that is just done when we have time and capacity. These are patients that are really high risk and we need to make sure that we are prioritizing them. And there have been things that we sort of have done within our service. So we have sort of changed to not seeing some below knee fractures, for example, to try and increase the capacity that we have to really be seeing as many of these vertebral fractures as possible. And one way that we know we can try and sort of streamline this is the administrative load. It's huge within all healthcare settings, and within FLS, it certainly is one of the things that we know that we have lots of work to do. So what that means is that actually, not only do we have the platform real to look at the vertebral fracture and the AI in that way, but we now have something coming to us called Real Plus, which is actually a database, which means that we can actually not only use a platform to identify these vertebral fractures, decide that they're an appropriate patient to bring into clinic, but actually feed them straight into an electronic system, which we can use then to actually sort of complete their whole journey through FLS. So it's important that we're uploading to the FLS database for us because that's a way that we can monitor how our service is performing. But the sort of the effort that's taken to do that at the moment is really high, and cutting down things like this is a way that we can really help to sort of increase our actual FLS activity in terms of more patients being seen. So what the Nanox team have developed is something called Real Plus, which is basically a sort of system that works not only with the AI side of stuff, but also this patient management system. So it just means that we can sort of take the patient right from that first identification point through to a treatment recommendation, and then also importantly monitor them at the end of that. So the database allows us to input all of the information that we need to when we're doing our consultation. It also allows us to generate a letter. So at the end of that, it's really important that we've got something that both the patient has as a record of the conversation that we've had in a way that's clear for them to understand, and also action points that they need to do next. So be that going to the GP to sort of get the medication we've talked about, but also that more clinical letter that will go to the patient's GP, but also scheduling those follow-ups. And obviously, as we've heard from Kasim, there's plenty of work that AI can hopefully be bringing to improve our monitoring. But at the moment, what we have is a schedule system where we have started a patient on treatment and we want to follow them up. And that's something else that sort of can come into this management system. And then, as I mentioned, at the end of the day, if we're not uploading all of this data nationally to look and compare how our service is performing, then what are we doing it for? We need that to drive further sort of cycles of QI to make sure that we're constantly evolving and constantly improving what we're doing. So that's work that we'll be doing within Oxford to hopefully try and streamline the service that we have, so that we can really increase the capacity to identify more of these vertebral fractures. And this is really just a slide, I know, I'm sure we all know why we're doing it, but this is just a case example that I just wanted to highlight. This is a lady who we identified using Real, and she was somebody whose CT scans over the course of sort of 2 years had changed from this on the left to this on the right, and actually throughout that whole period of time, not one of these vertebral fractures was identified. They were not mentioned in the report. She was being seen by other teams, and obviously these CT scans were being done for other reasons. But what was really important, and what I just wanted to highlight, is that this gave us the opportunity, because of the sort of quick progression in these vertebral fractures, to be very clear that they'd happened within a 2-year time frame, and we were able to go on to therefore offer her treatment with romosozumab, and she's had a great outcome from that. So it was just a really good example of the great work that identifying patients in this way can bring, and she certainly would not have been found if we'd stuck with our sort of method of looking at radiology reporting. So in summary, I think we've agreed that the use of AI when we're talking about vertebral fractures is a really effective way to consistently identify these patients in the absence of radiology reporting. And we know these scans are not being done to look for vertebral fractures, and therefore the reporting is really hit and miss. So by bypassing that altogether, we're having a much more consistent way of finding these vertebral fractures. We also recognise that there are more patients that will be found than most FLSs are able to have the capacity to deal with, and that's why it's so important that we look to make changes to the pathways we have, to streamline them where we can, and to really look at what we can do about that administrative load to try and make sure that we are finding the right patients and getting them onto the right treatments quickly. And as I mentioned, the introduction of romosozumab is an opportunity to make sure that these really high risk patients that we're finding with this technology are getting the most appropriate treatment. So that was a whistle stop tour there through my slides, and hopefully we brought back a little bit of time for Q&A at the end there.